And without further ado, research to practice, lymphoma management updates for 2021 with Ann W. Beaven, MD. And Dr. Beaven, welcome. We're so glad to have you here today.
Thanks. I'm glad to be here.
Good, good. Well, it's at least a few minutes ago here in this area, it was very rainy, so it looks like the rain's let up a little bit. So Dr. Beaven, you specialize in the treatment of patients with all types of lymphoma, including B-cell and T-cell non-Hodgkin lymphoma subtypes and Hodgkin lymphoma. Cutaneous skin lymphomas such as mycosis fungoides and Sézary syndrome are of special interest to you, and you also co-lead with Edith Bowers, MD, in dermatology, a multidisciplinary cutaneous lymphoma clinic. Do we have everything right so far?
That's right.
Okay. In addition to taking care of patients in the clinic, Dr. Beaven develops and manages clinical trials for patients with lymphoma. She is heavily involved in the development of the UNC Lineberger CAR T therapy program. This is an exciting approach that uses a patient's own immune system to help fight their lymphoma. And Dr. Beaven, what's one thing we should know about you outside of your professional portfolio?
I guess that I've played classical piano for years, but I think because I got so bored during COVID, I'm now trying to learn how to do improvisation.
Wow.
I don't anticipate much success, but I'm going to give it a try.
Well, good for you. That's good to know. Congratulations on pursuing something new. All right, so I mentioned poll everywhere, all anonymous. We try to make this first one a softball. Lymphoma is the most common type of blood cancer in the United States. If you think that's true, go ahead and plug in A. If you think that's false, B. Again, totally anonymous, and that will pop up in just a minute. And while we're waiting for that, I will say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, MPH, and CPD staff have no relevant financial interests or commercial interests or relationships as defined by the ACCME. Ann W. Beaven, MD, has no financial relationships with commercial interests as defined by the ACCME. And there's that polling question, and we're already getting responses in, so we'll wait about 15-20 seconds, give everyone a chance to respond. And it sometimes feels like when you're at the county fair and the race with the ducks or the horses or whatever else moving along, and it looks like A is in the lead. Dr. Beaven, how are they doing today?
I think they're doing pretty well. Amongst all cancers, it's about number 7, but within heme malignancy, we are at the top.
All right, thank you so much. And with that, I'll turn it over to you. Lymphoma management updates for 2021.
Okay, we can move on to the next slide. All right, so I was just going to start with one of my patients, and then we can go through different options and things. It's actually been quite exciting for the treatment of lymphoma in the past few years because after a long dry spell, there's been many different agents that have been FDA approved for relapsed disease. So this patient is a 29-year-old male. He was diagnosed back in March of 2020 with a primary mediastinal diffuse large B-cell lymphoma. The family history was interesting because he did have a sibling who also had a Hodgkin's lymphoma around that time. So he was initially treated with 4 cycles of dose-adjusted R-EPOCH, which is basically just a fancy way of giving an R-CHOP regimen. And this was completed in July of 2020, but he had one residual area of uptake on the PET scan, and we biopsied that and confirmed that he still had residual lymphoma. So because it was a very tiny area, we decided to go ahead and try and radiate that to see if we could get rid of those little bits of lymphoma left. Unfortunately, that didn't work for long. So that radiation was completed in October of 2020, but a few months later, in January of this year, his PET scan showed evidence of progressive disease outside of the radiation field. We can go to the next slide. So the question is, what would you do next for this patient? CAR T therapy, hospice, chemotherapy alone, chemotherapy followed by an autologous stem cell transplant, or chemotherapy followed by allogeneic stem cell transplant.
All right. Dr. Beaven, how are they doing?
Well, I'm very pleased nobody's at hospice because there's definitely lots of things to do for this patient still. And this is interesting. So the majority chose chemotherapy followed by autologous stem cell transplant. And currently for first relapse, that's typically what we will do. CAR T therapy right now, as we'll discuss, is FDA approved for third-line therapy or above, although there's lots of studies looking at it in exactly this setting. And then allogeneic stem cell transplant, just because it's so much more complicated, is something we usually will leave until someone's had multiple relapses. So let's go on to the next slide, Tim. So here you can kind of see this management of diffuse large B-cell lymphoma. So, typically we do this R-CHOP-like regimen, and you hope someone gets into remission. But if someone has a disease relapse or primary refractory disease, then we'll usually go on to chemoimmunotherapy plus autologous stem cell transplant. If, again, they're either refractory or relapse again, then we talk about chemoimmunotherapy followed by allogeneic stem cell transplant, although to tell you the truth, it's not that many patients who make it to the allo stem cell transplant, partly just because of the age of this general patient population. Let's see the next slide, Tim. So my patient, what we did next, so I give him chemotherapy hoping to get him to autologous stem cell transplant. So he got gemcitabine, cisplatin, and dexamethasone, which was completed in April. And his PET scan showed stable disease with chest nodes had increased in size a little bit, but not by 50%. So it was stable disease, not quite progressive disease, but certainly not what we wanted to see. Next slide. So we'll come back to that patient sort of at the end of the talk, but what I wanted to talk about was the drugs that have been approved for relapsed or refractory diffuse large B-cell lymphoma. So the last drug, until these listed here, that have been FDA approved to really make a big impact in diffuse large B-cell lymphoma was rituximab, which has been probably about 20 years ago since its approval at this point. So it's really exciting what we've seen in the past 5 years, where almost every year we're seeing FDA approval of a new agent. So you can see in 2017, we had the first CAR T therapies that were FDA approved, the Kymriah and the Yescarta product. Then in 2019, we had polatuzumab vedotin to be given in combination with bendamustine and rituximab. And I'm going to talk a little bit more about what these drugs are on future slides. 2020, tafasitamab plus lenalidomide approved, as well as the second drug, selinexor. And then even this year, we've already had 2 drugs approved, lenalidomide, tesirine, and then another CAR T regimen. Next. So it's really a super exciting time. I just put in 2 slides just to, I think many people by this point know what CAR T therapy is, but since I'm going to talk about it a little bit, I just wanted to put 2 slides in to kind of explain a bit more. So what it stands for is chimeric antigen receptor T cells, and basically this is a way of modifying the patient's own immune cells to try and set them up to target the cancer. So you take the patient's T cells and modify them so that they are looking for a specific marker on the cancer. So for the B-cell leukemias and B-cell lymphomas, at this point the marker that you're typically looking for is CD19, which is expressed on B lymphocytes. So as you can see here where it says CAR, you take their T cells and modify in the lab so that when they go back in their body, they're activated to look for CD19, kind of like an out-of-body vaccine against the cancer. Next. It's sort of a complicated procedure. The first, you take the patient, you have to collect their blood, and you have to isolate the T cells. Then they have to modify them using the viral vector so that they're expressing whatever antigen receptor you want, like against CD19 in this case. Then they have to expand the T cells, test them for safety, and eventually, after 2 or 3 days of chemotherapy, these cells are infused back into the patient to just sort of hopefully make this very big immune response against the cancer. And as you can imagine, doing all this takes quite a while. So for the FDA approved indications, usually it probably takes at least a month to get all of this arranged. And it has to be done at an academic center. It's not something that's being done out in the community. Next slide. So here are some of the CAR T cells that are FDA approved for relapsed refractory diffuse large B-cell lymphoma. And what you can see here is that all of them, I'm sorry, I have a typo on here. It says that they're approved for second line or beyond, but it's actually third relapse, or second relapse, so third line therapy. for these agents. They're all approved for diffuse large B-cell lymphoma, and some of them are approved specifically for primary mediastinal as well as transformed follicular lymphoma. And what you can see is high response rates. So these are drugs that were studied in patients with multiply relapsed disease, and you're still seeing overall response rates of 50 to 80% and complete response rates in the 40, 50, almost 60% range. These drugs have not been not been compared one to another. So these are 3 studies. So we can't look at these table and say that one drug is better than the other. I'm not going to talk too much about the toxicities today, but the big things that we worry about with CAR T therapy, one is called CRS, or cytokine release syndrome. And what that means is that the patient's immune system gets so revved up when they get these activated T cells back that they start releasing all sorts of cytokines, leading to low blood pressure, fevers, hypoxia. Patients can get quite ill. And particularly in the earlier studies, this could be a significant problem with sometimes patients ending up in the ICU and rarely even a death from this. Now, of course, people have gotten much better at taking care of this and sort of nipping it in the bud. So most of the time, we can keep people from getting severely ill. And then the second toxicity is neurotoxicity. And this can be anything from seizures to confusion, delirium, significant sedation. It seems to be completely reversible, but can be really pronounced when it occurs. Next. So here, what we can see is that these responses, when they occur, are relatively durable. So the Juliet trial slide in the upper left, you can see that probably about 40% of all patients who receive the CAR T are having durable responses, where we're getting out to about 3 months on this, 3 years on this, with a median progression-free survival is looking pretty good. And then when you look down the right-hand one, you can see what's not surprising at all, which is that patients who get a complete response have much better results. So again, the Zuma 1 trials, this is a different CAR T, but you can see if you look at the all patients line that the outcomes are fairly similar. So you're seeing about 40% of all patients who received the CAR T are having these durable responses. But when you just look at the top line, which is the patients with the complete response, those patients really are doing quite well and getting out to about 1.5 years after therapy. It's quite rare to see relapses. In fact, as you can see in both of these, most relapses when they occur are in the first 3 months, and after that people seem to do quite well. Now these regimens haven't been around for years and years and years, so we don't know are people going to be relapsing in 5 years or something. I'm not sure, but so far people getting complete response do have very good outcomes. Next. So just to kind of put CAR T results into context. So here I've put a few trials that were just of regular sort of cytotoxic, kind of classic chemotherapy. So the CORAL trial, which just compared 2 different chemotherapy regimens, DHAP versus a gemcitabine regimen, so second-line therapy. And then this other trial, the CCTG trial, which again compared 2 classic chemotherapies, ARISE versus R-DHAP, again for second-line therapy. And what you can see that those were patients who had, in the pre-rituximab era, in the CORAL trial, their CR rates were only about 14%, a little bit higher once rituximab gets added in. So in the CCTG trial, you can see complete response rates of the 30% range. And then when we get into CAR T, what we're consistently seeing is much higher response rates and higher complete response rates, kind of more in the 50% range. And these CAR T trials were more heavily pretreated patients. So those first 2 chemotherapy trials, the CORAL trial and the CCTG trial, were patients who'd only received 1 prior line of therapy, versus the CAR T trials, they've had at least 2 prior lines of therapy. So more heavily pretreated and having higher response rates and complete response rates. So really exciting. Next. Oh, so here's this question: for which of these is CAR T FDA approved? Consolidation after first-line chemotherapy for patients with high-risk diffuse large B-cell lymphoma, for first relapse, for second relapse or beyond, or all of the above?
All right, and if you would take just about 5 more seconds, please. All right, Dr. Beaven, how are they doing?
Really well. So this is right. So CAR T therapy at this point is FDA approved for second relapse or beyond. I think it'll be very interesting in the next few months, perhaps even at our American Society of Hematology meeting that is in December. I think we're going to find more about its role as second-line therapy. For patients in their first relapse, there's 3 trials with 3 different CAR T regimens going on, taking a patient in their first relapse, like the patient I presented, and comparing autologous stem cell transplant versus CAR T therapy. So it'll be very interesting to see what the results from those studies show. Next. So just to kind of update this, we still do the same thing right now for frontline therapy and for first relapse, but for patients who have, sort of a second disease relapse or have received multiple prior agents, then CAR T cell really is something we use at that point. Next. And what's been really interesting is to see how it has changed clinical care. So this is data based on the National Bone Marrow Transplant Registry. And what you can see in 2017 is when the CAR T is approved for third-line therapy or beyond for diffuse large B-cell lymphoma. And the gray line that goes skyrocketing up is the use of CAR T therapy. And it's a little bit hard to see in here, but there's sort of a tannish line that you can see in 2017 to 2018 drops by quite a bit. That tannish line is the line for allogeneic stem cell transplant in patients with diffuse large B-cell lymphoma. So what you can tell is that the approval of CAR T therapy really did change kind of the algorithm, where the use of CAR T went way up and the use of allogeneic stem cell transplant was cut in more than half. Next. So we already talked about this. I don't know why I put it in there twice. So let's move on to the next one. So one of the other drugs that's been FDA approved, so polatuzumab vedotin, and there's a lot of advantages, right, to these drugs. The other drugs I'm going to be talking about are ones that you can just sort of write your prescription for and they're ready to go, rather than CAR T where it's really a patient-derived sample. So polatuzumab vedotin, this is an anti-79 antibody drug conjugate. So in some ways it's similar to rituximab vedotin, a drug that you might be familiar with. So it targets anti-CD79, which is expressed on B lymphocytes, and it also brings a chemotherapy drug with it. Next. So a study of relapsed refractory diffuse large B-cell lymphoma, patients who had already received 2 or more prior lines of therapy. 107 patients were enrolled and 80 were randomized to either 6 cycles of bendamustine rituximab or 6 cycles of bendamustine rituximab plus this polatuzumab vedotin. Next. And what you can see is a significant improvement in response with the addition of polatuzumab vedotin. So these patients with multiple relapsed diffuse large B-cell lymphoma, those who got the POLA-BR had overall response rates of 45% and a complete response rate of 40% versus only 17% in the bendamustine alone arm. And the follow-up for this study isn't too long yet, but you can see already a significant improvement in median progression-free survival of only just under 4 months for the bendamustine rituximab to about 9 months from the polatuzumab BR, with also not statistically significant, but certainly a nice trend towards improved survival with the addition of polatuzumab going from 4.7 months to 12 months. And and then you can just see it in graph form here below. All right, next. And the other thing that was nice is that you always worry when you add in another drug, is that going to really change the toxicity profile? And really the adverse events were relatively similar between these 2 arms. You did see a fairly high percentage of patients who were receiving transfusions of blood and platelets, but that was both in the BR and the polatuzumab bendamustine rituximab arm, and grade 3 to 4 infections were also similar in both arms. Next. So one of the other regimens is FDA approved for relapsed refractory diffuse large B-cell lymphoma. This is the tafasitamab. It's an anti-CD19 monoclonal antibody, so another antibody, kind of like the CD20 for rituximab, another marker that's expressed on B cells and B-cell lymphomas. So this took 80 patients with relapsed refractory diffuse large B-cell lymphoma who'd received 1 to 3 prior treatment regimens, so median of 2 prior regimens. And they gave this drug in combination with lenalidomide. So they received lenalidomide for 12 cycles, and then the tafasitamab they got quite frequently, weekly for the first 3 cycles, and then on days 1 and 15 of subsequent cycles. And then after a year, they did not continue on with the lenalidomide, they just continued on with every 2 weeks tafasitamab until progressive disease. Next. So initial results were very encouraging with a median follow-up of 13 months. 37% of 80 patients were able to complete the 12 cycles of the doublet and went on to the monotherapy. Overall response rate was 60% and a complete response rate of 43%. And the responses were relatively quick, so median time to response was 2 months. And then those patients who did respond, median duration of response almost 2 years, which is also very encouraging. Next. Again, generally well tolerated. Neutropenia was fairly common for grade 3 and 4 neutropenia, but febrile neutropenia was less common in about 10% of patients. Grade 3 or 4 thrombocytopenia was seen. Grade 4 thrombocytopenia is really the level where you might be giving transfusions, and that was in about 5% of patients. Rash is something that we frequently see in lenalidomide and definitely was seen here with up to about a quarter of patients having a grade 1 or 2 rash and 9% of patients having grade 3. Grade 1 or 2 diarrhea was fairly common at 32%, but grade 3 or 4 uncommon. Many patients did have lenalidomide dose reduction, so about half of patients had at least one lenalidomide dose reduction. The initial dose was 25 milligrams, and about 3/4 of patients were able to stay on 20 or 25 milligrams, so most only had one dose reduction. When patients were just getting the tafasitamab alone, sort of in that maintenance phase, neutropenia was still seen, but not that common, and there was no grade 3 or 4 febrile neutropenia, none of the diarrhea or thrombocytopenia. Next. So we have longer-term results of this Allogeneic study of the tafasitamab and lenalidomide, showing even better than what was initially reported. Remember, before I was saying median duration of response was about 2 years. Now with more follow-up, median duration of response is going on 4 years, and median overall survival is about 3 years. So this is very encouraging, and as you would expect, the patients who are doing the best are the patients who've gotten a complete response. So that's the upper line on both of these pictures. Next. So another agent that's been FDA approved is rituximab tesirine. This is another anti-CD19 antibody drug conjugate. So this was studied in 145 patients with relapsed refractory diffuse large B-cell lymphoma who'd received 2 or more prior lines of therapy, but a median of 3. And for these patients, you get the drug on days 1 of a 21-day cycle for I left out a day there. The higher dose for days 1 of the 21-day cycle for 2 cycles, and then you get a lower dose for up to a year after that. Next. And what you can see is overall response rates of 48% and complete response rates of 24%, with a median time to response of just over a month at 41 days. And we can go on to the next slide. As far as tolerability, generally fairly well tolerated. You can have some infusion-related reactions with this. Any grade was 5%. One of the interesting toxicities to notice is that, although not severe, about 20% of patients did get grade 1 or 2 peripheral edema, a little bit of rash, and along with the fluid, just with peripheral edema, you can also see some pleural effusions with grade 1 or 2 and 8%, and 2% of patients getting a grade 3 pleural effusion. Half of patients did have liver enzyme abnormalities, so that's one thing to be monitoring for. Next. Another drug, this is an oral drug, selinexor. So this is a selective inhibitor of XPO1-mediated nuclear export. It was studied in 127 patients with relapsed refractory diffuse large B-cell lymphoma with 2 to 5 prior lines of therapy. And it's taken on days 1 and 3 each week until progressive disease. And they saw an overall response rate of 28% and a complete response rate of 17%, with the median duration of response about 9 months. Again, as with so many of these agents, thrombocytopenia in particular with this drug, as well as neutropenia, are fairly common. But they also saw a pretty high rate of diarrhea of any grade, about a third of patients, fatigue of any grade, almost half of patients, and vomiting was also seen in about a third of patients. I just point that out. I think many of my patients think a pill is going to be more easily tolerable than IV medicine, but these also come along with their own toxicities. Next. So which of these treatments is FDA approved for treatment of relapsed refractory diffuse large B-cell lymphoma? Selinexor, polatuzumab vedotin, tafasitamab, rituximab tesirine, or all of the above? Oh, my lights just went on. I'm going to go turn them off again. Sorry, they're motion activated in this room.
All right, and again, if you take just about 5 more seconds, please. Right, Dr. Beaven, how are they doing?
They are right. All of these agents are FDA approved for relapsed refractory diffuse large B-cell lymphoma. Next. So questions for diffuse large B-cell lymphoma management, to which we don't really have an answer yet, are how do we choose which treatment to use? I mean, we went from having very limited options to having many, many options that haven't really been sort of compared one to the other. And does it matter what order we use the treatments in? For example, several of the agents I discussed are antibody therapy against CD19, and then CAR T therapy is also targeting CD19. So one question is, if you use one regimen that's targeting CD19, will a different regimen still work? And then I had already mentioned a little bit, will CAR T or some of these other options move into earlier lines of therapy? Next. So all of those questions I mentioned are ones to which we don't have the answer. As I talked about, there are some studies that are coming out in December, hopefully looking at how CAR T therapy compares to autologous stem cell transplant in patients, in their second-line therapy. There's also going to be data talking about polatuzumab vedotin as part of frontline therapy. So it may be that some of the answers come out really in the next few months. But until then, I just wanted to talk about a couple of other things for which CAR T therapy has been FDA approved this year. And so it's been FDA approved for follicular lymphoma as well as mantle cell lymphoma. Next slide. So the ZUMA-5 trial, it looked at CAR T therapy. And so this took a phase 2 trial of 146 patients with indolent lymphoma, but the majority of them were follicular lymphoma. So 124 with follicular lymphoma. They had to have 2 or more prior lines of therapy, so a median of 3 prior lines of therapy. And what you can see is, I don't know if you remember when I was talking about the CAR T in diffuse large B-cell lymphoma, when for cytokine release syndrome, and some studies were seeing that up to about 24% of patients having grade 3 or 4 events. But you can see here it was much less common, only 7% of patients having that cytokine release syndrome. And part of that really is because we have a lot more interventions and things we can do. So as soon as someone starts having a fever or starts having something else going on, we sort of jump on that early to keep it from getting up to a grade 3 or 4. And then for neurologic events, about 19% of patients, it's hard to know whether this will play out or not, since there were only 22 patients with marginal zone lymphoma, but some suggestion that there were many more neurologic events in the patients with marginal zone lymphoma, with 41% of them having a grade 3 or 4 neurologic event. But for right now, this is not approved for marginal zone lymphoma. It is only approved for follicular lymphoma. And almost all these adverse events had resolved by data cutoff, and that's what we typically see with the neurologic events, that they do resolve. Next. So for response rates for follicular lymphoma, with 84 patients were assessable for response, with overall response rates of 94% and complete response rates of 80%. So remember, these are patients who had a median of 3 prior therapies, so a complete response of 80% is really quite impressive. For the smaller group of marginal zone lymphoma patients, again, high response rate, CR rate perhaps a little bit lower, but it's really hard to know with such small numbers. And these responses were durable, so we don't, one of the big issues, of course, with indolent lymphomas is these are lymphomas that people live with for years and years and years, and we don't know how to cure. So the 12-month sort of estimate of progression-free survival and overall survival is short for an indolent lymphoma, but we just don't have the long data yet to tell us, is this something that's going to cure follicular lymphoma? Is this something that's going to put most people into remission for 10 years, or what it's really going to mean for our patients? So it's estimated that the 12-month progression-free survival is that at 12 months, 74% of patients will still be alive without disease progression, and 93% of patients will still be alive at 1 year. So far it's looking pretty good, but time will tell. Next. And then another trial is looking at patients with mantle cell lymphoma. So it was FDA approved for mantle cell lymphoma in 2020. This study was for patients relapsed refractory mantle cell lymphoma after 1 to 5 prior therapies, so a median of 3 prior therapies. All of them had a prior BTK inhibitor, so like ibrutinib or acalabrutinib or zanubrutinib, and almost half of them had a prior autologous stem cell transplant. As far as tolerability, grade 3 or higher neurologic toxicity in about a third of patients, and grade 3 or higher cytokine release syndrome of 15% of patients. So 60% of 60 patients were assessable for response, and 93% had an overall response rate, with 67% of patients having a complete response rate. So again, very high responses. Next. And as we've seen with these the responses seem fairly durable. The estimated 12-month progression-free survival is 61%, which is actually a little bit higher than we're reporting in, say, diffuse large B-cell lymphoma when it was really closer to 40%. An estimated 12-month overall survival of 83%. So again, follow-up is short, but similar to what we've seen in the other CAR T studies for diffuse large B-cell lymphoma, it really seems like when people are progressing, it's within the first, 6, 8, 12 months. And once people get out beyond that, the numbers are fairly small, but it does seem that maybe there's a plateau and people are getting into some long-term remissions with this. Again, like follicular lymphoma, mantle cell lymphoma is a disease that we historically say that there's no treatment for it, no cure for it, lots of treatments, no cure. So we don't yet know long-term, what does this CAR T mean? Is it going to change, mantle cell lymphoma, or is it just going to put people into, hopefully, long responses? And unlike the other indications for follicular lymphoma and for diffuse large B-cell lymphoma, the CAR T therapy is FDA approved for second-line therapy. So for mantle cell lymphoma, they included patients with only 1 prior line of therapy in their trial, so it is FDA approved for second-line therapy in mantle cell lymphoma, whereas in the other indications it's for third line or above. That might be actually the last slide. I guess I went through them quickly today. But so in summary, many advances in new therapies have been FDA approved for relapsed refractory diffuse large B-cell lymphoma in the past 5 years. CAR T options are now available for relapsed refractory follicular lymphoma and mantle cell lymphoma. And I think a lot of the questions going forward are going to be some that I mentioned earlier, which is, does it matter what order we do these things in? Are some of these agents going to be used up front, earlier lines of therapy? And so I believe that's the end. I can't remember if I have another question. Oh, I was going to tell you what happened to my patient. So my 24-year-old patient with relapsed refractory diffuse large B-cell lymphoma, I did give him CAR T therapy. He received that in June. And just a few weeks later, he was having worsening pain, and we got repeat CT scans showing disease progression with the abdominal mass going from 3.1 to 2.8 centimeters up to 5.8 by 5.4 by 7 centimeters, and a second mass going from 2 by 2.7 centimeters up to 4.6 by 4.3 centimeters. Next. However, I thought it was very unlikely that his disease would really progress that quickly, and so what I was hoping, and I'm still hoping, that this is really what we call pseudo progression, where you put in this whole new immune system and all of those cells went to the tumor. And so suddenly maybe you had 1 million cells before, and now you have 2 million cells, half cancer cells and half the immune cells, the CAR T cells going there. And I thought that that made the most sense with just the rapidity with which things progressed. And I'm hoping that's true. So a month later, I repeated the CT scan, and you see that that mass that had increased it up to, 5.8 by 5.4 by 7 centimeters was down to 2.9 by 2.5, and the other mass had increased up to 4.6 by 4.3 centimeters. It increased down to 3.9 by 2.4 centimeters, and symptomatically, he was doing much, much better. So he's coming back, I think October 2nd, to get repeat imaging, and we'll see. But I'm feeling very hopeful that things will go well for him. Next. And that's it. So we have one. Do we have any more questions? I don't know that we do.
We do. We've got a couple that have already come in, and I'll go ahead and post those. And then I'd like to encourage everyone in the audience, please go ahead and submit your questions through Poll Everywhere, if you would, please. So first question, go ahead.
Yeah, so this is a really good question. So you mentioned some of the risks that accompany CAR T. Is CAR T less risky than auto stem cell transplant? That is, perhaps for elderly patients who might not be candidates for stem cell transplant, could they receive CAR T? So I think this is a really good question. In December, we're going to have randomized data telling us what's the difference in risks. So I don't have the official answer to that, but I would say that from my experience, I do think that CAR T is much better tolerated. For example, when my patients go to autologous stem cell transplant, there's a couple of things. They're usually in the hospital for 3 weeks and receiving lots of blood transfusion. Many of them, most of them will have infections, from their neutropenia and beyond antibiotics. Some of them can get quite ill from that. And people are really exhausted. Like when people come back to my clinic sort of 4 or 6 weeks after their transplant, the only thing that they'll tell me is they just say that getting a transplant was the most exhausting thing that had ever happened to them. So CAR T therapy, they do get a few days of chemotherapy before the CAR T, and occasionally a patient will get transfusions, and occasionally a patient will get a fever either from infection because of their neutropenia or just from the cytokine release syndrome. But generally patients do pretty well, and they don't get really exhausted the way they do with stem cell transplant. And while they do need to stay local, in most instances, they either don't have to be in the hospital or they're only in the hospital for a short time. So I do think we're going to find that this is something that's more tolerable than autologous stem cell transplant. The oldest patient I've treated with CAR T is probably 81. So we're definitely pushing the limits with that. And in the trials, they were treating patients up to about that age.
All right. So another question, what are the costs for CAR T drugs monthly or per year?
Yeah, so this is a great question. I think about this a lot. And what I haven't really seen, they may be out there, but I haven't seen them myself, is kind of looking at what is the cost of this. So some of the benefits, right? If this works, it's kind of a one-time treatment, but it's quite expensive. I mean, the cost of CAR T is probably similar to the cost of an autologous stem cell transplant. What I don't know is how does a one-time CAR T compare to, say, getting tafasitamab, for years and years until your disease progresses. And that's what we really need to find out more about, which is how does it come out in the long run? And then what would be really interesting would be doing some sort of assessments for taking into account how people are able to function their life outside of that. For example, if the CAR T ends up being more expensive than several years or several cycles of some of these other agents, but CAR T is sort of this one-time thing, and then they can get back to work and do other things, how does it all play out? And I think it's going to be really interesting to see that. The problem with CAR T is I think that it's always going to be somewhat limited to those patients who have the resources to be in an academic setting. They have to have, or it doesn't have to be an academic setting, but at least a big enough facility that they're doing CAR T. Typically, you have to have a caregiver with you all during that time, so you have to have somebody who can come, take time off work or come and be with you, or multiple people who can do that. So I think it's not going to be the answer for everybody, which is why I'm so pleased that we have these other drugs that are FDA approved.
Great. And another question, is there a pending SWOG DLBCL study at UNC? If so, what is the investigational agent? Thank you.
So right now we don't have a pending SWOG diffuse large B-cell lymphoma study at UNC. some of the studies that we have going on right now. Oh, you know what? I know what study you're thinking about. I don't know why. I forgot it was a SWOG one. But yes, so SWOG, Alliance, and ECOG, we have a study that we will be opening, which is specifically for patients who are older patients, so patients who are 75 or older with newly diagnosed diffuse large B-cell lymphoma. And what it's looking at is mini R-CHOP. So mini R-CHOP is sort of dose-reduced R-CHOP that we specifically decrease many of the doses for this older patient population. And in this study, it's randomized plus or minus oral azacitidine, because there's some data suggesting that azacitidine can help the chemotherapy be more effective. There is some data, not in this older patient population, but with this combination, which hasn't shown a huge increase in toxicity. So that study has been opened across the country. There were 7 patients on it last I heard, because it just opened really recently. And obviously we're going to be enrolling many more. I think it'll still be a few months before that's opened at UNC. But I'm really excited. And since it's in that older patient population, there's a lot of kind of studies looking at quality of life and functional status and stuff. We'll people on it too.
Right. And is there a clear relationship between tumor burden and the probability of success with CAR T therapy, durable PFS? That is it substantially more successful than successful at treating an initially smaller disease?
Well, I would say so. It's very interesting. So there's some question as to if someone doesn't have any disease, like if you use this just as consolidation or whatever, and you didn't have any cells around to sort of stimulate the immune system when it went in, maybe it would be less effective. And we don't know. I think that's more of a theoretical thing. It can be quite effective in patients with high tumor burden as well. But I worry in that setting that their risk of cytokine release syndrome is much higher. So typically I'd like to get somebody to have their tumor burden less just for a safety reason. And we are able to do that. For example, you can collect the cells and then give someone some more chemotherapy, in the 3 weeks or whatever, while you're waiting to get those cells back if you need to. So there is a little bit of opportunity to kind of treat people while the CAR T cells are being made. But yes, I think for me it's more of a safety question if they really have a high tumor burden. I'd rather, one, not have the big tumor flare, which isn't reported as much with CAR T, but it's kind of like I saw with my patient, and one, I worry more about the cytokine release syndrome.
Great, thank you so much. These questions are wonderful. Please keep them
I know.
coming. We do have a few more minutes, so that's great. Do you have concerns about treating patients with tafasitamab Rev before CAR T in rel/ref DLBCL?
Yeah, we do wonder a little bit about would that kind of modify efficacy, and we don't really have the answer to that yet. I'd say the little bits of data that are coming about suggest that that's not the case, at least that there are certainly reports of people receiving one and then still responding to the other. So we'll see kind of what comes out from that. But that gets that question I was saying that we don't really know, does it matter what order we go in or what order should we do first? We just don't have the answers to that yet because all of these drugs have all come out so quickly.
Great. Thank
I know.
You so much.
I'll tell you guys, these are like the best questions I've gotten in a talk in ages.
I will say we have an awesome audience, and I always like to brag on them. Oh, what is this one came in the chat. What is the window of opportunity to use CAR T cells after they are ready for reimplantation? So
basically, what happens is for the FDA approved indications, you send off the cells to whatever drug company is making that product, and they keep them. And you do not request those cells until you are ready to use them. But they could be having them for a year or more. It kind of depends on each one. But really, I think they're things that could be used for quite some time because they're keeping them frozen. And what's really nice is that at the moment, I don't know whether this will be long term, but at the moment, there's no charge for the CAR T cells until they are sent back. So if they're made and we never use them, that patient does not get charged for those. So, if you make them and then the patient gets too sick and doesn't get them or whatever, then the company, just takes care of that cost. So I think that is one nice thing about it.
Great. And while we're waiting to see if we get any last questions, I have one. If we were to, without the luxury of a way forward machine, if we were to have you do us the honor of coming back maybe in 2 years, what do you think you'd be talking about? What any projections on what will be new? What are the hottest trends right now?
I honestly think I'd be talking about a lot of the same stuff, but probably I'd be talking about, okay, what's the role of CAR T in Hodgkin's lymphoma? So at UNC, you know, we have a huge CAR T research. We develop a lot of CAR T regimens within UNC. And so one big area of research we're doing is targeting a CAR T against CD30. And so that's in patients with multiple relapsed Hodgkin's lymphoma, because CD30 is a marker you see there. And for some peripheral and cutaneous T-cell lymphomas as well, some of them express CD30. So I think that's one thing that we'll be talking about. Other things that might be interesting to talk about are Hodgkin's lymphoma. So what's happening with Hodgkin's lymphoma is similar to what's happening in diffuse large B-cell lymphoma, but a little further ahead is that there were all these exciting regimens, you know, a few years ago, new drugs that are FDA approved for Hodgkin's, and now we're trying to figure out what order do we give them in? Do we give them in upfront therapy? Sort of how do we take all of these regimens and really make them? So I think that that's probably what I might talk about in a few years.
Great. Well, thank you so much. We'll hope to have you back and see where we land. So,
well,
and then
Tim, if there's time, there was one more question that just came in.
Absolutely, we have two. So, and I'll load up the next one in just a minute. So,
okay.
If there has to be done, if this has to be done in an academic center, does that I would guess create a large barrier for care for patients right now? Are there referral processes in place for oncologists at other institutions? Great question.
Yeah, I mean, I think it is a big barrier for patients, right? Because to come here, if you live somewhere else, for many patients, that's not something that they can do. So I do think that you know, there's all sorts of equity issues and things like that for you know, the expense to come. So most of the companies do provide some help. For example, a lot of these companies that are making these drugs we can get money for people to stay in hotels or for the drive back and forth and things. So they're trying to help overcome some of those barriers. But I still think that for many patients, it's difficult to get up here and stay up here for that time.
Sure, and we do have wonderful resources like the Ronald McDonald House and the SECU House, which we're fortunate to have in this area. How are you sequencing options for relapsed MCL now with CAR T available?
Oh gosh, that's such a good question. I don't really have an answer. It's hard because we have the Bruton tyrosine kinase inhibitors, which are so effective in mantle cell lymphoma, and then we have CAR T therapy, which are so effective now as well. And so I really don't know. I'd say that because, and it may be partly because we do so much CAR T at UNC, I'd say that I tend to go to the CAR T. I like the option of doing CAR T because it really is a one-time thing versus if someone gets on a BTK inhibitor or lenalidomide or something else, these are drugs that they're at this time would be just taken indefinitely. So I kind of like that from the CAR T option for those patients in whom it's a candidate.
All right.
And then one more question.
Go ahead.
Are these CD19 targeted therapies for B-cell lymphomas likely to be tested next in T-cell lymphomas? I wish. So T-cell lymphomas is way more complicated. The T-cells don't express CD19, so these particular CAR Ts would never be used in T-cell lymphoma. But one of the problem with, so as I said, we're in our CAR T targeting CD30 in some T-cell lymphomas and the few T-cell lymphomas that express CD30. But it's much trickier for T-cell lymphomas figuring out what marker we should go after. Because when people get CAR T, the CD19 targets really all B cells. So these patients, their B cells are going to, even their normal B cells are going to be depleted for a really long time, but people do okay that way. But if we're targeting a T cell and we suppress all of their T cells, you know, now you're talking about patients who can have really serious complications. I mean, if you think about HIV and other things where some of the T cell population is going down. So I think it's going to take us a lot longer to figure out what kind of a target can we go after in T cell lymphomas.
Right. Well, Thank you, to Dr. Beaven, and thank you to our audience for all of these phenomenal questions. Before we close, let me go over a few things. We want to say thank you to the team, Mary King, Veneranda Obore, John Powell, Oliver Marth, and Jason Paler for all of the hard work that they do.